we're starting to let folks in, and if we can monitor participants coming in, Jennifer, as well, we'll know when folks are here. Just a quick note for those of you that are signing in, the session is being recorded, and there should be notification of you of that. So I think, how are we doing, Jennifer? Can I just start?
Yes, we have 25 attendees so far. They're still rolling in.
I'll give it a couple more minutes. Yeah, I'll give it a couple more minutes, and then I'll do the official welcome for folks and say a few things about vernissage, and then we'll get started on time. Okay. So I think let's get going. And so welcome. Thank you so much for registering for this webinar. It is sponsored by Vernissage Health, and I'm Wendy Nelson. I'm founder and the project lead for Vernissage Health. We are an initiative within the Dalla Lana School of Public Health and IHPME, and our focus is on developing the next generation of health leaders in our system. And the webpage, if you're interested in the project, is there. I'm delighted tonight to be talking about the work culture post-pandemic and what we as emerging and established leaders can do to build a more supportive work culture in healthcare. And before I start, I want to recognize the partners and the funders of Vernissage Health, and that includes the Dalla Lana School of Public Health, IHPME, and we've been very blessed with the support of Associated Medical Services, so AMS as well. Tonight, there are a number of folks on the panel that you're going to hear from who have been part of the Vernissage Health Initiative. First is Dr. Izzard Dabinski, who started in Vernissage back in 2018 as established leader and became a co-lead of the project in 2019. And he's going to be the host today. But I want to give mention to three of the emerging leaders that have had the Vernissage experience. Jennifer Gutberg, you'll meet her, Brandon Tang, and Zara Ishmael. All three were emerging leaders, and I'm just so delighted that you're here to be part of this tonight. And also Rue Tagger. Rue was an established leader in the alumni pilot last year, so we're delighted to have folks that have participated in Vernissage Health in the series. So with that, kind of welcome, in introduction, I'm going to turn it over to Izzard Dabinski, who will get things started.
Thank you, Wendy. I'm Izzard Dabinski. I'm, as you have heard, a colleague of Wendy's and an adjunct professor and senior fellow at the Institute of Health Policy Management and Evaluation. I want to welcome our attendees, and we have well over 200 registrants for this evening's program. Many of you we know are young leaders, and many of you come from a variety of backgrounds and are working in a wide variety of settings, both in the community and in the institutional setting. The reason that we thought it was important to bring this program to you is because it has become obvious to all of us that COVID has posed a huge challenge, both to patients and providers of all backgrounds. Tonight's focus is twofold. One is some of the issues and challenges that have arisen to leaders during the COVID crisis, and subsequently now as the numbers of hospitalized and critically ill patients are falling after the crisis has passed, and also to talk about the impact of COVID on the culture of healthcare delivery. We know that there has been a huge amount of stress and burnout among providers. We know that there are now people seeking new opportunities for staff in hospitals. Many individuals are leaving their healthcare professions. We recognize that many of you have been beset upon by picketers outside your institutions, all of which have created even more stress for many of you and more opportunities to revisit the culture in healthcare. And our panelists tonight will be addressing all of those issues during this webinar. You've already been introduced to Jennifer. The first of our panelists is Anne Borden, who is a writer, a podcaster, and a patient advocate. You will also be meeting Rue Tagger, who is the Executive Vice President and Chief Nursing and Health Professions Executive at Sunnybrook Health Sciences Center. Zara Ismail, who is the Project Director for Transitional Care and Community Integration at North York General Hospital. Dr. Gillian Hawker, who is the Chair of the Department of Medicine at University of Toronto and a Senior Scientist at the Women's College Research Institute. And Dr. Brandon Tang, who is a resident in General Internal Medicine in the University of Toronto program. With those brief introductions, we are going to begin the panel, and I'm going to start by asking each of our panelists to describe what their current experience as leaders in the healthcare workplace during the pandemic was and what it is now. So we'll start perhaps first with Anne, if you don't mind.
Izzard, could we, maybe Jennifer would like to say a few words about
yes, of course.
the audience,
Please.
about the chat, and just how people can, while they're listening to our speakers, how they can ask questions.
Thanks, Wendy. And I'll make it very quick because I know we have a tight schedule tonight. So just to let you all know, I know with these webinar formats where you can't see other people's faces other than the speaker, oftentimes it can be difficult to feel engaged, but we strongly encourage you to ask questions in the chat, bring conversations. You can have discussions with one another in real time in the chat. My role here is to moderate the discussion. We will not be taking direct questions during the sessions while the panelists are speaking, but I will be keeping track of all the questions and we'll be saving those for the end. So I encourage you to leave questions and comments throughout the discussion, get engaged in the conversation, and feel free to answer one another if you have thoughts that you want to share.
With that, we will now turn it over first to Anne.
Hi, everybody. My name's Anne, and I was diagnosed with stage 2 bilateral breast cancer in May of 2020. I had 2 surgeries, chemo and radiation during various waves of the pandemic. I first want to say thanks for inviting me because I think it's really important right now for patients and healthcare professionals to be connected around this issue. We have a shared experience these past 2 years. And I mean, I would call it a shared trauma of receiving and providing care during this crisis. And I'm really glad that you invited a patient and that we're connecting in this way. Having cancer is scary, and having cancer during a pandemic is really scary. I think for patients like me, one of the biggest fears was that procedures would be canceled during these times. Life-saving interventions would be canceled. And that fear was kind of realized, especially in the West earlier this year. So I'm very grateful for all the treatments that I've gotten, the timeliness of the treatments and the hard work that providers have put into it. Today, I'm focusing on some of the issues and problems that need fixing from a patient perspective. First of all, I was lucky to have my breast cancer diagnosed at all. That was in May of 2020. I saw a change in my breast and I emailed it to my provider because at that time, they weren't really taking appointments. And so that's kind of how I got in to even get an appointment. So I was very, very lucky that there was a noticeable sign because they were also not doing exams in 2020 pretty much. So I wouldn't have had the typical exam that I normally would have had. So I think that, I certainly think that it would not have been detected at all if I hadn't had a physical sign of the cancer. And I think the cancer would have progressed beyond stage 2 if I had not had that visible sign. We all know that there are patients who did not get to see their GP or get routine screenings for 2 years, now showing up at ERs with end-stage cancer. And I think that's one of the takeaways of how things could go better next time for patients would be really that checkups, routine screenings, and GP visits are really essential care, and to be really careful about how much virtual care can really replace that. So that's my first thought. Then generally my experience with cancer care in 2020 was rather chaotic. I think hospitals were rather chaotic at that time. It was a very disconnected experience compared to other forms of healthcare I've gotten in my life. I learned that I was going to need chemo on a phone call, from an oncologist I had never met. And that, was really difficult for me to understand and get the right information about my treatments when everything was in such a chaotic place. I didn't get a port for my chemo because that was kind of an extra thing that, unfortunately I got a serious vein issue later on. So I think that some of the protocols and some of the things around that were problematic. I think the visual that comes to my mind of that summer that I was getting chemo was the hospital was kind of scrambling around to make space in the waiting room at the chemo lab. They had to have a chair between each chair, and there weren't enough seats for people to sit in at all because every other chair was blocked off. And so I would end up sitting on the floor by the elevator while I was waiting to get my chemo treatments. And to me, that really kind of symbolizes the chaotic nature of getting treatment during that time. And there are other stories I could tell about things that went wrong for other patients. And I think though one of the things that added kind of to the stress of it was that the rest of the society was kind of rushing to reopen. It amplified these feelings inside of really feeling alone and afraid of becoming sort of collateral damage. I think my takeaway from that is that healthcare institutions in the next crisis could kind of improve communication for patients and really invest in that so that patients really get a bit more communication. My final thing that I wanted to mention about my cancer treatments is during all my cancer treatments, I was alone. I wasn't able to bring anyone in with me, obviously, for very sensible safety reasons. So I'm not saying there should have been more visitors allowed in the hospital, but I am saying that without any family or friends by our side, we also lacked advocates. So I think one lesson from the entire experience of the pandemic would be that healthcare institutions could maybe build more safeguards into the treatment so that there are advocates, maybe roaming advocates or somebody there to advocate and also provide some of what was missing from the patient experience of not being able to bring anyone with us. And I guess like the final thing I would say kind of in conclusion is my experience with healthcare really encompassed all the words on that screen in the thought cloud. I was struggling to adapt to the chaos, and I was also fearful. I mean, the thing that people fear always is that they're not going to get the care and they're not going to be okay. So that would be kind of the takeaway, I think, for what could be worked on in terms of both processes and communication. Thanks.
Thank you very much. So let's perhaps now ask Brandon and Dr. Jillian Hawker for their answer to that question in terms of your experience, Brandon, as a leader of residents and postgraduate trainees, and Jillian as a leader of an academic unit and a chair of a department of medicine. What are your reflections of your experience in COVID, both as leaders and its impact on the culture within your organization or peers?
Thanks, Izzard. I'll start us off. And thank you everyone for coming to talk about this very important topic. Jillian and I came up with a story that serves as a metaphor for how we feel the current state of the healthcare culture is. And I'm sure it will sound very familiar to many of you. So imagine there was a small town with a wide river coursing through the middle of it. At the bottom of this river, there are dozens of people who are drowning, and bystanders are frantically trying to save them. But no matter how many they save, it seems like there's always another who takes their place. The community has tried everything. They've tried adding more lifeguards. They tried doing swimming lessons so that those who are drowning could be more resilient to this. One day, someone comes along and they walk up the river and they find dozens of bridges that dozens of bridges that are in complete disrepair. So it's no wonder that people have been falling in this entire time. So needless to say, many of us in healthcare feel like we are drowning in the ever-increasing complexity, volumes, and responsibilities of our system. And as you heard from Anne, many of our patients feel the same way. But for too long in our work culture, the focus has been on what the individual can do. Be resilient, do yoga, do modules online, take time off work, but not on the system that is broken or the parts of the system that are broken. So we feel that burnout is fundamentally a systems problem, and we need to address the root causes, these broken bridges, which is one of the central words in our word cloud. So over to you, Jillian.
Thanks, Brandon. I think we all know that an aging population, diagnostic and therapeutic advances, an explosion of information technologies and precision medicine, consumerism, social media have all increased the number of people that need care, the patient's demands for and expectations of care, the complexity of care, and the administrative burden on healthcare providers to provide that care. These factors have really substantially reduced the individual physician time spent with their patients. And for instance, the Ontario Medical Association has shown that physicians spend about 2 hours on average on electronic documentation for every hour that they spend in direct patient care. At the same time, we're realizing that whether or not we've ever said it, we've actually got a culture of medicine in which we've made it noble to burn yourself out. We pride ourselves on being there and going and going and going. But our younger generation of physicians, Brandon's colleagues, I hope, are pushing back appropriately so, raising concerns to people like me who are looking at how do we keep things moving about whether or not we're actually going to have enough physicians to provide the more complex and administratively burdensome care that we need to provide going forward. And COVID simply laid bare these facts that were already there. What have we done to address these imbalances? Not much. We've mostly done what one of my colleagues described as spectacular workarounds. We keep adding and adding. We never take anything away. And we add things in a very ad hoc, unintegrated way. And everything we add administratively or disconnectedly takes away the precious time that physicians have to take care of their patients, and in academic medicine, also to teach and to do research or other scholarly work, and of course, from their daily lives. There are many organizations who have appointed wellness leads, but to my knowledge, those wellness leads have not been given authority to make change. They're not sitting at decision-making tables. There's no way for them to intervene when yet another crazy improvement administrative task is imposed on the front line. Bottom line, physicians are struggling to find the deep satisfaction that being a physician can provide and does provide. Less time spent in meaningful work, taking care of patients, means more burnout. Thank you.
Thank you very much, Brandon and Jillian. And now, Rue and Zara, if I could ask you to address that question.
Thanks so much, Izzard. So as a leader, I would characterize the situation as being complex. Each wave during the pandemic came with a different set of challenges. The challenges ranged from PPE shortages, supporting long-term care, to bed capacity issues. The residual impacts were interrelated and cumulative. And amidst all of this, there was a key element of commonality. We had the same group of healthcare providers and leaders that were expected to pivot and respond to all of these different challenges. The cumulative effect of this pivot and response has resulted in a workforce that is feeling unhealthy, and at times feeling unsafe in their ability to deliver care. Our teams have used the following words to describe the way they feel. They've told us that they're feeling exhausted, tired, morally distressed, and staff have told me that they feel like they're widgets where their work feels transactional in nature. This is all happening within the context of our society at large, which hasn't stopped changing. So I'll hand it over to Zara to speak to that.
Thanks so much, Rue, and thank you for having me here today, and to all the participants for joining. So as Rue mentioned, I'll maybe take a bit more of a broader society lens. From that lens, we all experience and continue to experience some form of social isolation. We have been distanced from our loved ones, colleagues, missing the human connection. And weirdly, social isolation has become an experience that's most common for all. Probably the only shared experience, with the exception of the weather. So no matter who you are, what you do, what system or sector you find yourself in, what role you hold, we each had the shared experience of longing for human connection during the pandemic. Furthermore, despite 4 generations in the workforce, ethnicities, values, traditions, and how we differentiate ourselves from one another, we all remember the 7 p.m. banging on the pots and pans, being in the streets and on our balcony. There was kindness and empathy that was extended from our community. There was much beauty in that, and elements of that have continued today. On a personal note, as a healthcare leader, during the pandemic and during the first 2 waves, my partner and I lived in a very small condo. I remember Zoom had taken off, probably Google Meets, WebEx, and Teams as well. And we were both sitting side by side at one of the tables we have. He was in a Zoom meeting right next to me and caught my elbow in his screen. I remember thinking, how can this be normal? But I also remember feeling confused, worried, uncertain. How will I lead a team virtually? What does it mean to be a leader in a virtual sense? And on a much more personal note, how would I be able to see my grandmother in the nursing home? Thanks, Izzard.
Thank you all. I'd like to move on now to another question. Once again, we'll start with Ann Borden as the first respondent to this question, but Ann and others, from your perspective, if health leadership does nothing about the current situation, and you've done a masterful job about informing us about the difficulties of the current situation, what do you project will happen? Perhaps, Ann, we'll start with you again. And you're muted.
Sorry about that. Yeah, I've broken my answer into 2 parts, worst fears and best hopes. One of my worst fears relates back to what we've been talking about with virtual care. I'm afraid that not enough will change back to the way it was, specifically with regards to annual physicals, routine cancer screenings, and in-person exams. I really worry that it's going to become even more like dystopian, and that patients and healthcare professionals will become even more distanced from each other. Although there are benefits to virtual care, I really do worry that it's going to go too far. Here I'm going to quote from Dr. Alan Broom and colleagues, who wrote in the journal Clinical Cancer Research in November 2020, and I'll paste that in after my answer. They say, quote, COVID-19 is reshaping oncology practice, clinical trials, and delivery of cancer care broadly, and these changes might endure well beyond the short to midterm of the active pandemic. And this is a great paper. They talk a lot about equity issues around that as well. I think it's great if we can look to a future where surgeries are no longer being postponed, but there would still be many unsolved problems in cancer care. In the worst scenario, the poorly conceived virtual care model being used for the past 18 months would be adopted partly in the name of austerity and efficiency. And then we would continue with this sort of nightmare of undetected cancers and difficulties receiving treatment. We could also face a cascade of social problems that impact health, like undetected and unreported child abuse and domestic violence, which health providers had been doing as part of mandatory reporting via in-person well child appointments and checkups. In the worst scenario, other issues as well as health conditions and injuries might be neglected, causing patients pain and suffering and seriously compromising our quality of life. In the worst scenario, there isn't a mandate to really get back to in-person care. More unnecessary tests are ordered, ironically driving up the costs and also driving down the quality of care, quality of patient experience, and quality of work life for physicians, as Jillian mentioned earlier, would suffer. This would have sort of a divide and conquer effect as well, breaking the human connections between patients and their providers. And with that missing, we would be steered further towards a competitive two-tiered health system as well. In that case, even after things settle down with the pandemic, our care would be forever altered with staff attrition, more cuts to capacity. Universal healthcare funding would continue to be devalued and underfunded. Then the further that patients drift from their providers in terms of real world connection, the less the public will also be invested in the universal healthcare system. My best hope is that we identify weaknesses in system capacity, then look at best practices and come up with new creative solutions so that we can fix things for now with an eye to the future. In that regard, we need to rally policymaking allies around public health system. The healthcare also needs some new leadership and new kinds of leadership with diversity, with patient involvement. I'd love to see more cancer patients and patients with disabilities more actively involved in how administrations rebuild their systems. I know that some hospitals are reaching out with surveys, which is great, but I think they need to hear more than just the lived experience of patients. I think they need to hear the ideas of patients because we've been inside the system. And then I think for their part, the patient-oriented groups too need to break a little bit free of the charity designation and move a little bit more towards advocacy. I think everyone's going to have to do more advocacy to get us out of the difficulties that we're facing right now.
Thank you very much. Jillian and Brandon?
Thanks, Izzard, and thanks, Anne, for sharing your perspective. So when Jillian and I were preparing for the seminar, we completely recognized that COVID was like this stress test that shed light on so many different problems. So maybe it was the thing that broke some of the bridges, but it needs to be made clear that things were falling apart or damaged before then. So COVID may have brought out the issues, but many of them were pre-existing. So it's relevant not just to a COVID era, but both the past and the future. And one of the things that we think is at stake is actually the relationship between providers and patients. It sounds like things really can't go on like this. And one of my fears is that we're in this spiral where both parties are going to be growing increasingly dissatisfied. So I'm relatively early in my training as a learner, and many of us, myself included, went into the profession because of a calling and a passion. And this was my life dream. I called my parents in tears of joy the day I was accepted to medical school. But for the reasons that Jillian described, our work has transformed into something that takes away from us, that drains us as opposed to serving as a calling or something that energizes us. And I think that our patients feel this too. When you're pulled in a million directions, when you're rushed and you're reaching for the door to leave before they finish what they're saying. So we think that what is at stake is this relationship between providers like physicians and their patients, which is the central aspect of what is a human-centric profession in healthcare. And then taking a bit of a trainee-focused perspective, one thing that I worry is that this current work culture where people are dissatisfied, where people feel rushed, it feels like an assembly line or widgets, as Rue alluded to, that this system or these values are going to be ingrained in learners who are very impressionable. Because there's actually excellent evidence that the things you learn in your training, they imprint on you and they lead to habits way down the road. So for example, you can trace back differences in quality of care for surgeons decades earlier back to where they did their residency training, despite the time that has passed. So my fear is that in this culture of burnout and growing dissatisfaction, that these are the values that are going to shape a generation of trainees at a time when they're very impressionable. Over to you, Jillian.
Thanks, Brandon, and thanks, Anne, too. It's interesting. I was going to start with the same thing, that I don't want to go back to where we were before COVID. That's probably the most common refrain I hear from physicians. Please learn from this. And I think of the word cloud we saw, disheartened is probably the word I hear most frequently. So as Brandon said, physicians are really struggling to find that deep satisfaction that comes with practicing medicine. I actually heard a group of third-year medical residents say that they didn't have time to talk to their patients. They're busy with going on to 4 or 5 different IT sources, internet sources, looking at results and trying to comb through online medical records. And, that's not how you practice medicine. So the eating away, the erosion of that time spent practicing medicine to manage administrative and technological demands of this broken system will have and already has had enormous consequences. Burnout is rising. We're talking about it. It was already there, but it's tangibly rising. We know that burnout is very clearly connected to the amount of hours that physicians are spending doing those widget tasks as opposed to indirect patient care. And I've already said that we're spending way too much time on stuff that's not direct patient care. Physician suicides are going up. In the past year, the Ontario Medical Association's Physician Health Program, which docs don't put up their hand to ask for help, it went up 40% in the past year. And I don't think COVID put us over the edge, but we were already heading there. Exhausted physicians can't provide the same compassionate health quality care. So patients obviously suffer when physicians aren't able to practice the way they were expected to practice and want to practice. And I worry too that medical residents won't so much imprint, but they won't learn how to effectively communicate with patients and their families. They won't learn about that important therapeutic alliance and how to build trust with their patients, because you can't have that therapeutic alliance without trust. And right now they're getting tapped on their shoulders to do 40 different tasks instead of spending that really serious quality time listening to a patient's story. I worry that those stories will be gathered from online data rather than from the patients and families themselves. And because patient care will always be prioritized, and I am in academic medicine, everything else that academic physicians do will have little time, and there will be little bandwidth with which those physicians can inspire Brandon's generation to be the best they can be, to advocate for and engage in transformational change, which I think most physicians feel is a responsibility, a privilege of their profession, to be creative and to excel in science. This will also eat away with their self-worth, because our self-worth is tied to the quality of care that we deliver and our potential ability to contribute to society. I expect some physicians will retire early, others will move to part-time work, and more physicians will be unable to work due to the impact of burnout. And maybe some people, like Brandon, will decide not to go into medicine, which would be an incredible loss. Thank you.
Thank you. Rue and Zara?
Thanks, Izzard. So I would say, yes, the current risks are very real. And I would characterize them similar to what Brendan and Gillian have said, related to poor health outcomes, potentially, definitely compromised patient experience, which Anne has spoken to. And we already are seeing this through the excessive backlogs that we have within the healthcare system. We will continue to see healthcare workers exit their jobs if we don't do anything more about this situation. And we'll see healthcare organizations competing with one another for health human resources, which is already happening. Finally, we'll have a situation where we're going to have to reduce services, which there is a significant threat of that occurring now. And services could be related to ICU beds, not having enough capacity for critical care patients when we need that capacity the most, or, delivering trauma care. So it could be quite significant in terms of our ability to provide timely access to care. Brandon talked about what's at stake between the healthcare provider and patients. I'm going to add to Brendan's point by saying we also have what's at stake between our staff, our healthcare providers, and healthcare organizations, the employer. And I would say what's at risk there is the culture. And I am seeing an emerging culture of apathy that is happening within healthcare institutions, which is understandable, but very concerning. And also a culture of transactional care, which I've mentioned before. Thanks very much.
Zara?
Yes, sir, can you hear me okay? Yeah?
Yes.
Okay. So the good thing about being last, or maybe the bad thing in this case, is that all my previous colleagues here have touched on everything that could possibly go wrong or that is going wrong right now in the system. So maybe what I'll do is I'll hone in on a few key points that I think are important. COVID truly has been a tipping point. Burnout was already in play at 30% of the healthcare workforce. During the pandemic, it increased to 60%. The other key point I'd like to mention as well is the regionalization of services. So as staffing decreases, or we speak to it as shortages, nurse-patient ratio increases, our mental health increases or decreases really, what we will end up seeing in the system is that ICU beds and specialized services like cancer care will be a lot less. And so our patients will have to drive farther, go the distance, go to the next city in order to acquire these services. The inequities will only increase, and the haves and have-nots, the difference between them, will increase as well. And what I mean by that is people will need to find a way to access healthcare. And those people that are able to and can afford to will pay for it and will be crossing the border. And so I think Anne mentioned it earlier on. Our system will look different, and the healthcare system that we are so proud to call our own as Canadians will also look increasingly different. Thank you.
Thank you. Our final question for the panelists is this. In your opinion, as a healthcare advocate or a patient advocate or a healthcare system leader, what needs to change, or what actions do leaders have to take in order to create a more positive and a sustainable healthcare workplace? We'll start again with Anne.
I think action really needs to focus around defending our universal publicly funded healthcare system. I think we need bolder policy advocacy, broader public education efforts, and more inclusion of patients in the conversation. So on a macro level, I think it's really important for us to address that there's another crisis and that's well underway, and it has to do with health disinformation and distrust in medicine and the impact that has on the viability of our public healthcare system. Things could have been better in this pandemic if it were just a disease we were battling, but there's a broader related crisis, the rise in a populism that's driven by hate. It's a hate that turns out crowds to protest our healthcare centers. COVID may have been the match for that, but as people have been saying, the tinder was laid well before the pandemic, in great part on our largely unregulated social media networks. Our universal health system is in a battle right now, not just against COVID, but also against disinformation, and the healthcare leaders really need to be disruptors and stop the flow of that disinformation. This disinformation network, this health disinformation network, is a huge threat to our health system. Basically, because of their setup, alternative healthcare providers can offer a lot more of the soft side of treatment. And that is one reason that vulnerable patients, such as cancer patients, often turn to alternative health, because they're getting that soft side, they're getting the long appointment, they're getting the reassurance, they're getting the types of things that they may need emotionally from these competitors and disruptors from alternative medicine and that are promoting health disinformation. Patients and healthcare providers right now, because of all that we've been through, we have a bond. And I think that we all understand what's been going on, or many of us understand what's been going on inside of hospitals. We really need to maximize our bonding right now and to keep and grow the connection between us to work on trust and relationship building, and together come up with strategies to take on really the bigger issue that's impacting the system that people are starting to talk about here in this seminar, that there are many small things that need to change, many administrative things that need to change. Every little thing that needs to change is related to the bigger and broader change. And I think people, both in patient advocacy and in professional advocacy, will just need to be a lot more bolder and think outside the box to take on these bigger challenges.
Thank you very much. Brandon, Jillian?
So with the running analogy or metaphor that I've been using about the bridges, there's this famous quotation which goes something like, every system is perfectly designed to get the results it gets. And in this case, meaning that, if we had this system of like poor linkage between hospitals and primary care, and we didn't have excellent virtual care infrastructure, and then we completely leaned on it, perhaps some of these consequences could have been predicted, and we need to fix the underlying problems, which is what Jillian will speak to. Some of my points will be about what we can do in healthcare right now to cope with these work culture problems that we're having, and burnout, and the provider-physician, provider-patient relationship. So first of all, as we've been saying, we think it's important to acknowledge that the issues with our work culture and burnout are fundamentally a systems problem, and that this messaging about resilience and then individual actions needs to be reversed, because it's become somewhat of a dirty word where people feel blamed for their own burnout and lack of wellness. So we feel it's critical for leadership to acknowledge the underlying systems issues and make a commitment to changing them. And kind of like how Anne said, a lot of this has to do with the messaging and influence of the public discourse. So for example, like CEOs and Dr. Hawker, a lot of them have these blogs or forums where they communicate directly to members of their organization. And I think all of us saw during COVID, there's a movement now where providers and healthcare leaders are talking directly to the public. Through writing, through forums like Twitter, and that actually is an opportunity to shape discourse and to fight misinformation, as Anne was talking about. Secondly, acknowledging that there are problems and things are bad is important. Because we need a culture of peer support, because things aren't going to be fixed in a day. So a big part of this, in our minds, is creating venues for people to share stories and be open about their vulnerability. So to use a very concrete example, there was this excellent memoir who Izzard actually shared with me for the first time, which is called We Are All Perfectly Fine, which tells a doctor's deeply personal story about her own struggle with burnout. And then every provider I've spoken to has found this so cathartic, because the message is that we're in this together, our experiences are shared, but we'll also get through this together. So through things like town halls and storytelling and seminars like this, it's a way to share in each other's experiences and let us know that we're supporting one another. But taking a step back with respect to peer support, it also needs to be driven through the organization. So groups like the American Medical Association, the Ontario Medical Association have recommended new roles like chief wellness officers in healthcare organizations to oversee the consequences that are happening within organizations, policy changes, procedures that adversely affect provider and physician activities. They recommend that this be a full-time role and a paid role and an empowered role, as Jillian was alluding to, giving this individual the ability to actually impact change when they see these adverse consequences. And then over to you, Jillian, for sort of the systems lens on all of this.
Thanks, Brandon. I'm going to go off script for a second. I think the most important thing I've learned in a leadership role is when people can't agree on how we want to fix things or what's the best way forward, if we focus them on why we're all here, and we're all here for one reason, and that is patient care. And that suddenly sort of calms people down and they can focus. And frankly, I think the system has lost focus on why we're all here. So as Brandon alluded to, we think we need to rebuild the system from scratch. We are not dealing with the same system that we built 50, 60, 70 years ago, which was younger people with acute intermittent healthcare issues. Now we've got an aging population with multiple complex problems, but we're still fighting the fires the same way. We haven't really advanced that much. So we've got an outdated system. We've made incremental advances, but we can do much better. So I really want to dismantle, and I'm optimistic that we can do so under those organizational wellness leads that we're going to implement and give power to. We need to review existing workplace administrative policies and procedures and ask ourselves, which of these ones actually are giving value to patients and patient care, and which can be streamlined better or aligned with other requirements, and which can actually be got rid of. I haven't thought of anything being got rid of at my hospital for a while. We need to promote successful models of integrated primary specialist care. We've got them, we've built them, we've valued them, evaluated them, but we haven't really invested in implementing them and scaling them to the level to keep people out of the hospital. We need to engage with government in real health human resource planning. We need to really understand what our workforce looks like and should look like, back to what the people are that we are caring for. And I totally agree with Anne, I think, around the breadth of healthcare professionals. We don't need doctors for a lot of the things that our patients need, and we need to really look at the breadth of all of the people that could be playing a part in taking care of and preventing illness. We also have to look at our healthcare professionals themselves. We built a system based on 70-hour work weeks and a little woman at home. That is not the reality of 2021. And we shouldn't assume that it's the reality. We have to understand what people want from their lives, what they can handle, how many patients is realistic to be able to provide care for in a manageable way, and with what team around. And finally, we need to rebuild those bridges that connect public health with healthcare. We have dismantled them. We've pretty much dismantled public health, and we need to rebuild public health because the upstream causes of all of these health issues are well before the healthcare system is hit in education and the other social health determinants. And we in academic medicine and medicine overall have to pay much more attention to those upstream causes. Thank you.
Thank you all very much. I have found the discussion thus far very moving, very illuminating, and very educational as well. I'm going to provide each of you now with a 2-minute opportunity to reflect on what you've heard from your peers and colleagues and provide us with your kind of key points or key issues that you would like to bring to everyone's attention before we move to the questions. And may I remind everybody that if you do have a question, please put it in the chat box. Anne?
I think there was a slide for the takeaways from my.
There is, Anne. I'm just trying to get it up.
Great. Yeah, I mean, lesson 1, I think, is that checkups and routine screenings and GP visits are essential care. Even now, after vaccinations have happened across our country, there's still a difficulty in getting some of this care. And so there needs to be better communication. People are still kind of being streamed to the ER or streamed to scans and specialists. Because so much has been done online, sometimes it can be tempting to kind of just, end up stuck in that area, and then related, of course, to different changes in administration. So that's the first one. The second one is that virtual care, like I just said, virtual care should not translate into more scans and less visits. Communication is the top priority. I think with clear messaging, patients need reassurance that their healthcare is being prioritized. The public communication plans of different hospitals around COVID safety and cancer care was very, very different between different hospitals. So thinking about that before the next crisis, I think when patients can't safely be accompanied by family, friend, or friends, I think that is a safety issue. Patients are very vulnerable, like in the recovery room and other areas of the hospital. And without having someone there to advocate or help you communicate, is very, very difficult, and there need to be some systems put into place. If visitors are not allowed in the hospital, then alternatives have to be created to make sure there's another set of eyes in some of those spaces, and more assistance for patients. And then finally, advocating beyond the walls of the hospital or the clinic, which obviously I come out of advocacy and activist background. So in my opinion, I think we need to work hard on the big picture and defending science and universal healthcare, talking to policymakers and going into those social media spaces like someone was mentioning, and really taking control of the social media spaces to meet people, the disinformation people on their turf, and start to really build a better way of communicating around science and medicine so that people really feel very invested and really honor our universal healthcare system so we can protect it.
Thank you. Rue and Zara? Oh, sorry. Well, let's move first to Jillian and Brandon.
Thanks, sister. I think in all the excitement, Rue and Zara were going to share their change actions. So maybe I'll pass it back to them before I summarize.
Okay.
You know what, we can combine our responses. So I will just very briefly say that moving forward, we definitely need a vision. We need a good line of sight of what we're striving to achieve, and it needs to be very clear to us. So for example, as it relates to our workforce, what does the workforce of the future look like? I would say we need to strive to achieve a workforce that is viewed as being an attractive opportunity for the next generation of our learners. A workforce that feels healthy, a workforce that feels confident that they could provide safe and quality care, and a workforce where the supply meets the demand or the need. I think in order to achieve this, leadership is key, and transformational leadership is really a key enabler to making this happen. We saw evidence of that during the pandemic, where we were being transformational in our approaches, albeit it was stressful, but we were making decisions in a way in which we'd never made those decisions before. We were interacting with long-term care. We were supporting different sectors in the healthcare system. We were making decisions, extraordinary decisions around PPE and vaccine administration. And that was transformational leadership in its finest, quite frankly. So we need to harness what we've learned in our approaches that were effective, and we need to continue to translate them into the future. And then finally, I'll just make the point that many have already made, and I just want to emphasize it one more time. This is a system solution. It's not for every individual organization, and I see comments in the chat around what do? We need to work together to do it as a healthcare system and not piecemeal, which quite frankly, I worry that that's happening right now. So we need a system in place that brings us all together to work collectively to develop strategies and solutions that are happening in a coordinated way, and that is not sort of where we're incrementally in a piecemeal nature, picking at bits and pieces. So I'll stop there. I'll turn it over to Zara.
Thanks, Rue. I think what I wanted to speak about is our workforce of tomorrow. And when I think about that, I think about the workforce of tomorrow being the whole person serviced and not simply pay for the time that they're on their shift. And so the whole person is meant to mean their sense of purpose, their values, and their priorities. And when I think about elements of the whole person and how we can tactically implement this in organizations, I do have 5 components. The first is redefining the week by having flexible schedules. And we've all seen it through the pandemic, working from home, maybe staff working on multiple units. But what happens if we stretch our thought a bit more? Why can't our staff work within a system where sectors don't exist? And how come we don't think differently or not confuse the whole person's free time with their availability? Secondly is ensuring their loved ones are cared for. So this can translate into working parents having their children or elderly parents being taken care of as they're working. Third ensuring that their role links to the person's values and provides opportunity for them to contribute beyond their shift. So perhaps partaking in organization decisions. Next, compensation and incentives. Let's talk about sabbaticals, bonuses linked to quality outcomes. And finally, wellness. Brandon touched a lot on this. Wellness is meant to be in all our buckets of our lives. And all organizations, as Ruse mentioned, need a vision and a framework to promote and encourage wellness. And each organization needs to ensure that the framework is flexible to serve the diverse needs of every individual. So for example, there are organizations today who are providing $100 to each employee to decide where they want to spend on their wellness. And it's a huge leap forward. The other item, which Brandon did touch on as well, is the psychosocial support. At what point do we need it? How is it available? Is it per person? Is it for teams? And so I think discussion and dialogue about the workforce of today and tomorrow needs to be had. Thanks, Izzard.
Thank you. Brandon and Jillian, back to you.
Thank you so much, Izzard. So I may be the most junior person on the panel, but Dr. Hawker challenged me and gave me the opportunity to try and end our section. And I wanted to leave you all with a call to action. So we've given this new analogy over and over about these broken bridges, which represents the system. But who is going to fix it? Whose problem is it? Is it going to be government? They have a mandate of 4 years, so it can be challenging to have that long-term horizon, which we need to take. And as Rue was saying, is it going to be individual organizations like hospitals? The challenge is that the incentives of an individual group doesn't necessarily align with what is best for the system at large. And we were reviewing the attendees for today's seminar, and we saw that all of you are emerging leaders, or most of you are, from different settings, downtown hospitals, community sites, the private sector. And we truly believe that it's groups like the one that we have gathered today, all of us together, who have the power and the skills to fix this system. You all have skills and interests in leadership and scholarship and innovation that makes you part of this academic medicine community. It's not about where you're working, but rather this interest to drive change in the system. So together we have the experience and know-how to rally the troops, write proposals, gather data, test these changes. We aren't heroes in healthcare, to give a nod to the title of this presentation. We're just humans. Humans that want to get back to doing what we do best, which is looking after our patients. And we believe that through conversations like the one that we're having right now, that we can fix this system, our healthcare system. So thank you so much for listening.
Jillian, did you wish to add anything?
I
Thank
think
you
it
all
was
very
said
much.
beautifully.
I'm going to now turn it over to Jennifer, who is going to share with you some of the questions that have been arising in the chat box and ask each of you to answer them as Jennifer sees appropriate. Jennifer.
Thanks, and thank you all so much for a really inspiring hour. I think what I appreciated, and probably what all of our attendees also appreciated, is that you really were able to take the conversation from what Brandon started with, this individual level that we've all been stuck on for so long, to the system level. And this is the conversation that we need to have. So we do have a number of questions, but before I get to them, and I think it speaks to actually a lot of the ending comments that were already shared. One thing in a very practical sense that I'm curious about, and that speaks to at an overall sense, some of the questions that came up. There is a need to rebuild, as Jillian said. There is a need to create a new system, but we're operating in a reality of healthcare workforce resources and burnout and all of the things that we need to do. So the question to the panelists is, what is it going to take to help people sustain momentum for transformative change? Because that takes energy. And there's this risk that we're leaning towards right now that people are just so desperate to be okay that they just want to get back to the status quo. But the status quo wasn't serving anyone. So what needs to happen individually and collectively to keep the momentum and build it towards this meaningful change?
Maybe I'll try that one because that's the $1 million question. I've been trying to figure that one out. People are exhausted, but there's a kernel inside, at least my department members, most of them, that one, doesn't want to talk about COVID anymore. Two, is curious and excited about the fact that, wow, through COVID, just as Rue said, we did do a lot of innovative things. And my goodness, we got things done way faster than the bureaucratic engine would ever normally let it happen. So I do think there's enough people with enough passion about not going back and making things better that nobody's going to walk. They're not going to walk away. We've got it, but we've got to get everybody aligned. It's a stupid answer, but anyhow, that was my answer.
I would add by saying, I think we need to really dig deep and get a better understanding of what's required. So if you were to ask me the question, so, what do staff really want? What do they need? I actually don't know the answer. I think I know the answer, but I feel that we need to ask in a deep way, given the current context, what is going to make you feel valued? And I appreciate that people may not even know the answer, but we need to at least ask it, and we need to ask it with sincerity and in a deep way. And so I think we need to understand first, and we need to accept that maybe we don't completely understand the situation right now, and we need to dedicate our time to get a better understanding. I've heard things like staff are saying they want more flexibility in the way in which they work. There's lots of ideas, but I think let's try to dig down deep and understand it a little bit more before we go and act, which is my worry, because that's what we do in healthcare. We act and respond quite quickly. But this is a deep issue that we need to understand much better.
I want to underscore that, because that is what I was trying to say about understanding what the patient needs are right now. What's the 30, 40-year view? What are the health professionals, and who's the best health professional for what situation? And how do we partner with public health going forward? And I agree, Rue, it's going to take a lot of deep thinking and learning.
Can I also add, I think it is for us as a system to look at other sectors as well and see what they're doing. And Rue, I know that you and I have talked about this quite at length. And I actually wanted to finish off my last point with a quote. And I hope I can take this time to do that now, if that's okay, Izzard.
Please.
It's by Adam Grant. And I'll definitely share the quote, but I also want to make mention of something in the chat written by Taylor Martin. Sorry to point you out there, but we do need to talk about the workforce of tomorrow, but we also can look to other sectors to see what they are doing for us to have a sense of lessons learned. And so Adam Grant shares, the great resignation isn't a mad dash away from the office. It's the culmination of a long march toward freedom. Flexibility is more than choosing the place where you work. It's having freedom to decide your purpose, your people, and your priorities. I really believe that is what we need to do as a system to understand who is in our workforce today, what is important to them, and to then understand our leaders of tomorrow. Thanks.
Thank you so much. And I'm glad that you vocalized and acknowledged Taylor's comment, because it's generally generating reflection in the chat. And I think we all really appreciate what you had to say there. So I'll move on to some of the more concrete questions that were guided by the audience. And this one is by Anne-Marie Malik, and also spoke to the conversation that Anne really started us off on, but came up repeatedly, which is around this notion of virtual care. So it was implemented out of necessity during COVID, but one question is around how do we sustain it? And then the other question is around how do we do it properly? What are the right modes of virtual care? Where did care suffer for being remote versus where it can be enhanced?
Hi, Jennifer. I can take a stab at that one. So just reflecting back, I remember at the start of the pandemic, this buzzword, well, unprecedented was the buzzword, but another buzzword was sort of like catalyst. And people talked about how COVID was a catalyst for change, and virtual care was one of the classic examples. So if you think of a pendulum, I guess I really like metaphors, maybe it swung too far, and that we were overusing virtual care, and there was an over-reliance on that, and it led to situations, unfortunately, like the one Anne described. And some of the provincial organizations have recognized that as they, for example, in BC, where I used to work, they made comments about how a subset of people were overusing it, and some patients had to were developing late presentations of disease and driving up emergency room visits. So the pendulum swung too far, and the question is, where is it going to settle? I think it's challenging because every specialty is going to use it in different ways. So for example, in British Columbia again, there was a vascular surgery group which increased access to surgeons for the entire province. Whereas like most people live in this small segment of the province, there were so many people who didn't have access to surgeons. So that was definitely a boon for their particular specialty. There's dermatology virtual clinics, which are serving patients in different provinces than the one in which they work. So I think every particular specialty and aspect of the healthcare system is going to have to figure out what works and what doesn't. And I think the pendulum did swing too far, and we have to find that point of equilibrium.
Thank you, Brandon. Is there anyone else who wants to answer before I move on?
I would just say that technology, I mean, it's a very simple idea, but technology isn't the answer to everything. And I think that it's always like kind of cool to look at technology and see how technology can work. But then we can really see from the experience of what's happened in the pandemic, how technology not only has had, this reliance on technology not only has led to some really bad health outcomes, but also it's led to a somewhat of a disintegration in quality of patient experience and quality of work life for providers. So we're all people, like we want to be together, and I think that it should be, we should be able to say that, that we do want to maintain these connections. They're really important for all of the quality of life and quality of patient experience, quality of professional experience, and they're also important. Really, they're the oxygen for the entire system. So I would say to be wary, of new technologies just replacing things that are actually might not seem important, but are important.
I can just add something, and I hear what Anne's saying totally, but there are a lot of people that were really happy not to pay $25 for parking to get a blood result discussed with them. So I think I really want to bring it back to what Brandon said, is that there's a right place and a right time for different kinds of interactions. And that's what we're still learning. Where is it bad care to not see the patient virtually? Where is it better care to see the patient virtually? And I think that goes for patients too. My husband's a community pediatrician. He's got parents that don't want to bring their children in to be seen because it's much more convenient calling the doctor and asking for a prescription or whatever. So I think it goes both ways. We all have to learn when's it best for the patient and when isn't it? And there's a lot of work that still has to be done.
Thank you so much. Okay, we're going to move on to the next question. So this is, again, initiated by something that Anne shared in her segments and was voiced, quote unquote, by John Henderson in his question. So the question is ultimately about, what do we do with this fact that patients had to go through cancer care treatments and all kinds of aggressive treatments alone in a hospital, when we know that that's a risk for safety, we know that's a risk for quality and psychological above all, and emotional well-being. So from a patient perspective, perhaps, Anne, you can answer, you recognized in your talk that from a safety perspective, it was reasonable that you had to be alone, but at minimum, what would you have needed to feel supported in those moments during care? And then from the provider perspective, what do you think that the system can do to prepare so that when this happens, if it's another wave of COVID or the next crisis or the next outbreak of whatever it is, there's a plan in place that is patient-centered, but also addresses safety and infection prevention? And maybe Anne,
yeah, I mean, I'll kind of pass it over to everyone else, because I don't have an exact solution, but obviously there needs to be someone in an advocate role around. And so how that plays out, well, that's just a question that people are going to have to figure out, work it into their systems.
I mean, I will add, I remember being around the table when we were making decisions about, restrictions to visitors and guidelines related to that. And we were using sort of a risk matrix. We were weighing risks. We were acknowledging that there's risk when you don't have your loved one there, when you're hearing for the first time about a difficult diagnosis, and the risk related to that and the support that you may not have available to you. And we were weighing the risks of that with the risks of transmission and outbreaks. And it was a continuous titration and evaluation. And sometimes we got it right. And as Brandon said, sometimes the pendulum was swinging one way, a little too far at times, then we were swinging it back and learning along the way. What was most important that helped inform that discussion was we actually had patients around the table, and we were hearing the patient perspective. We were still quite provider-centric, and I still think, Anne, we need to do more in integrating the patient's perspective when we're making these decisions. And I think that's one thing is harnessing more of that perspective and seeking it, and actually having you guide us at times, and then us discussing from a clinical perspective where there are risks and coming to some kind of understanding or approach, common approach. But I think, we just need to continue to harness, and it's a balancing act. And I think we need to accept that we're not always going to get it right, but we need to be committed to a process that enables the most effective type of decision-making that we can achieve. And it needs to be in partnership with our patients and families.
Thanks so much, Rue. Just give a last chance if anyone else wants to share. Okay, hearing none, we will move on to the next piece. So this was something that Wendy shared in her question, but Emily Steele also asked. It's really about the concrete, what can leaders do in the here and now? And we started talking about that a little bit, but I'll ask for additional reflections, and it can be at the unit level, it can be at the organizational level. Think about your spaces and the positions and the roles that you occupy, and perhaps instead of answering hypothetically, answer in the way of, if you tomorrow had to start doing something, what could you do? And I know that's putting people on the spot. So I will let whoever feels brave enough jump in first.
Well, I have to do it, so I am going to respond. So I think many of the things that we've all said, and I expect Rue and Zara, et cetera, are in the same place. So one, we have put a lot of resources in place to help with the well-being of, for us, it's the docs and trainees, but the resources aren't enough. We have appointed wellness leads and are helping with the sharing of the stories that Brandon talked about. So really just trying to provide the on-the-ground support to people right now. We've also got individuals that the university had put together to really just be points of contact around how do I get things done. So I think a lot of attention to the here and now of well-being of all of the individuals that are in the healthcare field. Secondly, we're working with systems engineering, ministry, and members of our department, scientists on taking a deep look at health human resource planning. And I totally agree with Rue that we can't just do this from a physician side or a nursing side or whatever. We have to do it holistically, but I don't see anybody really doing it. So I think it's better to start someplace, but we need to know what we need coming into the training pipeline. And I am very worried that if we don't make some recommendations, we're not going to have any nurses or any physician assistants or any physicians. So I think the health human resource piece has to happen. And the third thing that I think we also mentioned, there's lots, but the third thing I'll mention is those wellness leads. I sit on what is the TAS and Medical Affairs panel, or the Toronto Academic Health Sciences group. We've got wellness leads, but they're not making decisions. And to my knowledge, we still haven't got enough effective removal of policies, procedures, decisions that actually have healthcare providers, all healthcare providers involved. We do a lot of, well, this will be devolved from this health professional to that health professional or back and forth, but nobody's really looking at the whole. And I think that what can we get rid of that I mentioned earlier has to happen because we can't do anymore. We need to start devolving stupid things that are in the workplace that are largely a result of silly bean counting as opposed to real patient care.
Thanks so much, Jillian. And I will ask if there are others who have thoughts on this.
So I can share my thoughts as a trainee, but I think it also applies to those who live mostly in the clinical sphere. So for tangible things that we can do, I'd say the first is to participate and partner. So it's so easy to just be in those proverbial water cooler conversations, which for me is the emergency room consult room, and just talk about what the problems are. And then you just have this echo chamber where everyone says the same thing. It's a lot harder to send an email to your chief resident, to someone like Dr. Hawker, and identify some of the problems and actually drive change. I don't think that applies to people here because you're here and you're participating, but to spread that to your colleagues and those that you work with. And the second is more about systemic advocacy. I think that there's never been a time, more so than now, where individual people can really shape the conversation. People are sharing stories on Twitter which go viral and really shape culture and the way people think. People are writing opinion editorials on news forums. That's how I got to know Anne, actually. And that can shape culture and shape how people think. So I think that, yes, there's organizations that can drive this change, and there's leaders, but also individuals, people earlier in their career, people mainly engaged in the clinical space, we can shape the dialogue as well.
Thank you so much, Brandon. And I'll just note this kind of speaks to a comment that Eric shared recently, which is just really about accountability. How do, we say we need to come together, we need to build the bridges, but how do we keep people accountable? And Brandon, I think that what you just touched on is really important and speaks to the first question I had for this panel, which is that in order to move systems forward, it starts with a coalition of the willing. That's just the nature of the beast. That is just how it starts. You get the people together, you start the conversations, and you find out who those people are, because as you just said, Brandon, there are power dynamics. There are people who might want to, but not feel safe coming forward just because that's not how it's been done. But if we create these environments where people across different professions, different platforms, different leadership roles can come together, it shows who's there and then creates the foundation to start building outwards across the system. So I think this is really helpful. And yes, we need accountabilities, but first we need the coalition to be built. And I think that's where we're at now. And I also just want to thank John Henderson for starting to put together our summative PowerPoint slide to share with the ministry about the key points that we need to take away for this, to bring things forward, including silly bean counting versus real patient care. So we are only have about 5 minutes left for questions. So first of all, before moving on, I just want to flag, and it may have gotten lost, Wendy did share the link to the survey, the post-seminar survey evaluation. It's very brief. We encourage you all to take a moment to fill it out because we want to hear your thoughts, what you liked, what could be improved. A link will probably be shared as well again after. I'll include one at the very end so it doesn't get lost and so you don't have to go digging around for it, but just to make a note of that. So there is one question that I don't think has really been addressed elsewhere. So I will ask it directly in the words of the participant, Ariel Berger, and apologies if I'm mispronouncing any names. How is academic medicine going to recenter the focus on patient care? Currently, there is nothing in our annual review and promotion procedures that actually looks at patient care. And I think given this panel, that's an interesting question. I'm curious what your thoughts are.
Well, I think it's to me. And I know Ariel, and she's wonderful, but actually academic promotion in our department does value patient care and include patient care because the process of promotion now requires people to tell their story of what they've done in a scholarly way, which largely relates to the patient care they're providing or they're passionate about the future to make an impact. So the bottom line is, what is your story? What have you done? Why is it important? And what impact have you had or will you have on the care of your patients or the health of Canadians? And we added that. That is not a requirement for promotion, but in our department it is. And I think it does change the focus to the impact of work, not just, doing stuff for the sake of a big publication, but doing stuff because it matters.
Thank you so much, Jillian. So just a moment now. So we're just about to wrap up. I'll pass it back to Izzard. I will share a link, reshare the link that Wendy shared for the evaluation. I encourage you all to take a moment to resubmit. There you go. Wendy already shared it. I don't have to. And I will pass off to Izzard to wrap up. And thanks the panelists for answering all of the questions and taking the time to share perspectives with the audience.
So first of all, I'd like to thank Wendy for all the work and energy she put into arranging this session this evening. It takes a lot of time, a lot of energy, a lot of communication, and it's difficult, I think, for all of us to appreciate how much goes into planning this session. It would really be helpful for all of us who have been involved in the planning to receive your feedback. So let me echo the plea that you fill in the evaluation. I would like to thank our panelists for taking time and energy from busy schedules, especially in crisis times, and for their openness and candor about some of the challenges that they have faced as individuals and within their organizations. And last but not least, thank all of our attendees for sharing their time with us this evening. We look forward to future opportunities to communicate with you. And for those of you who are interested in the Vernissage Health Program, I would encourage you to be in touch with Wendy at the website for Vernissage that we shared with you earlier. Once again, thanks to all of you and good evening.